Right. Also, thank you. You took again, you took that question right out of my mouth. So I appreciate you talking about the accountability. Um, Dr. Greaves, did you want to go ahead and go next?
Yes, I'm the last one,
Awesome.
right?
Yes, you are.
Okay, perfect. Sorry for being late, everyone. I know I was supposed to be here earlier, but my mom had a flat tire. I had to go get her. So, stuff happens. We adjust. Um, my portion is we're going to be talking about risk assessment. That scary little risk assessment part. Am I able to share my screen?
You should be able to.
Okay. Um, risk assessment. I cannot stress enough. If it wasn't written down, it didn't happen. And I'm sure that this is kind of a pattern that's repeated through all the speakers today, but especially if you guys are doing risk assessment and documenting the assessments that you're doing. Um, think about if this goes to court, how is this going to look? And how is a lawyer who knows nothing about therapy going to take this, right? So let's say that you had a patient and first session, you just automatically assess, like, hey, do you have any suicidal thoughts? And they said no. And then you're like, okay, great. And then you move on with your life. And you didn't write it down because it's just what you do. Um, and let's say that patient takes their life and then you get sued by the family and you're gonna go on the stand. The lawyer's gonna hand you the file and say, show me where you assessed for suicide. And you're gonna be like, well, I do. It's part of my routine. It's what I always do. They're gonna say, show me. Show me in your file where you did. And you're gonna say, well, it's not in there, but I do. And they're like, so it didn't happen. You didn't assess for suicide. You didn't meet standard of care. And you will lose that court case. So I want to stress, if it wasn't written down, it didn't happen. That came from one of our camp lawyers. So that always happens in the back of my mind. So always document. Um, so I always get asked, like, what do I include when it comes to the crisis risks that section? So what triggered an assessment in the first place? If it's your first session, then you can just automatically just put that you assessed for suicide as kind of a, you know, this is part of your assessment. But if you're mid-treatment with someone and they've had no suicidal thoughts, like every week it's been no risk, no risk, no risk. And then all of a sudden it's therapist assessed for suicide. Why? Why did you assess for suicide? What triggered that assessment? Was it a change in the patient's life? Like, what did they go through a breakup? And so you checked in with them? Was it all of a sudden behaviorally you notice that they're not really taking care of themselves anymore? Emotionally, were they crying a little bit more than usual? What caused you to say, I should ask? Because if you think of your notes as kind of a continuation story, it needs to be said of if you did an assessment out of nowhere, everyone's going to be like, well, why did you do that? So just put what triggered that assessment. And then what assessment did you do? So if you did an assessment, what was it? Did you assess for child abuse? Did you assess for self-harm? Did you assess for suicidal ideation? What did you do? I use a lot of scaling questions. I know you've heard that from like everybody before me today, which is great. Um, what I love about scaling questions, it's super concrete, especially when you're dealing with crisis. So I work with my area of research has always been in self-harm. And so I'm constantly doing risk assessments. Every patient, I'm always doing risk assessments. And so they know. And I just throw it out there like, hey, on that scale of 1 to 10, where are you at today? So you define what that scale is. And then when they give you that response, let's say they're like a 2, you need to have them explain, what does a 2 look like, right? And it's such a great way of measuring if they're progressing, if they've regressed. It's just really great. So make sure you put that. Um, then you have an estimation of suicide risk, right? If we're dealing with suicide, from now on, I'm just going to talk like we're talking about suicide. Okay, because that's suicide and self-harm. This is what I do. So, you have to estimate it. As part of our job, during our assessment, we try to gather as much information as possible. And then we have to figure out, okay, where is this patient at? Is this a low um, level so I can just do a safety plan and move forward? Is this more moderate where I need to increase contact? Is this severe where I'm starting to now think about looping other people in or sending them to the hospital? Where are they at? Once you create that estimation of that suicide risk, then you can go into more of your action plan. So based on your estimation, what did you do? Right? It's not enough just to say, oh, I did safety plan. What did you do? Be specific. And then what were the outcomes of that action plan? Did you end up having to send them to the hospital? Or were they able to agree to the safety plan and participate fully and understand what was going on? So you need to include all these things. So I always like to think about like detail versus vagueness. And here I think about like standard of care. So first you need to put that you actually did do risk assessment, which you're supposed to do. Um, but then I also think about legal implications. Again, if I ever get sued, sorry, let me take a step back. I never want my patients to end their life, right? That's never something I want. Um, Unfortunately, we are in a business where that might happen. And some of this documentation comes from, I want to be the best clinician. I want to make sure that I did everything possible. And secondly, I want to cover myself legally, right? So I always think about the legal implications. For the rest of your note, like what everybody was saying, vagueness is okay as long as you're tracking progress, right? Like Lauren and Francis, and I'm sorry I missed Renee. Um, but they did a wonderful job of detailing like, hey, this is what you would want to include. When it comes to the risk assessment part, detail is better. Details, quotes, it's all going to be um, relevant for this. So I always like this example. This was actually from one of the camp lawyers. It was from one of my law and ethics things that I attended. So the camp lawyer actually brought this up because this was a real case. The names have been changed. And so Kunkelman is a patient, brought with him to his appointment with Dr. Siegel a handwritten summary of his symptoms, which noted suicidal, frequently prayed to die. During the interview, however, Dr. Siegel noted, so in his documentation, he noted no suggestion of psychosis, delusion, or suicidality at such point. Unfortunately, Mr. Kunkelman did commit suicide, although he did so well after the note was written. But the lawyers in that case tried to use the ambiguity of the note to suggest to the jury that Dr. Siegel was negligent. So normally I have you guys pull out your pens and papers. Um, so I hope I'm not going to have you guys do that, but I hope you guys are willing to participate a little bit. Um, how is this? Like, do you think that this is detailed enough? So he did his assessment. He said no suggestion of psychosis, delusion, or suicidality at this point. What else needs to be in there?
Some quotes.
Yeah, maybe some quotes from the actual note, right? He brought a note with him to session. You can shout
Would
it out.
he use like that as evidence by and then their quote or
Yeah, you absolutely. I use as evidence by all the time.
Thank you.
Personally, I do not like abbreviations. So putting what is it? AEB, I hate that.
Maybe body language.
You can note body language in here. So how was the patient presenting, right? A lot of times, like I review your therapy notes, and at the top you have to put on there the like how they're presenting, right? Their, what do they call it? Mental status exam, right? And I'll see like all normal. And then I'll see in the risk assessment like suicidal. And I'm like, how is this? No, no way, right? So yes, you have to put in there the assessment if he had the intent, means, planned, right? Especially since he shared the note. I will say, unfortunately, because of the outcome of Mr. Kunkelman, Dr. Siegel was found negligent criminally. So you guys need to document. This is why documentation is so important. The law specifically says that you have to take reasonable steps to prevent suicide, which means that you have to document. The standard of care means you have to do the assessment and everything else, but your process doesn't end. It ends after you document. And this is my last thing here. So I have a sample risk assessment. And I'm going to read this, and so that way I can highlight certain points. Okay. Therapist assessed for suicidal thoughts and urges. Patient reported experiencing suicidal ideation and urges, in addition to experiencing thoughts of how to carry out a plan to hurt herself. Okay, so right here, I just explained that not only is she having thoughts and urges, but she also has thoughts of a plan. Okay, so I can't ignore that. On a scale of 1 to 10 for intent to complete suicide, 10 being plans to complete suicide, 1 being not at all, notice how I define the scale. It wasn't just a random ambiguous 10. Patient reported being a 2 at the time of session. Patient described a scale of 2 being having minor suicidal thoughts, but not having any urges or triggers. So again, here I am talking about what does this mean, right? What does the scale mean? Patient described her suicide plan as, quote, taking sleeping pills. Patient agreed to contact her crisis numbers and stated she would call 911 and notify 2 emergency contacts so that they know I called 911 and they would get my location to find me. Patient described that her suicidal thoughts and urges are, it's not like I want to die, I just don't want to feel this way anymore, but I don't feel like I have any other options. Okay, so just based on that information, I'm like, okay, like she's more than low, probably moderate, um, maybe leading to severe. Patient described her coping skills when she is experiencing suicidal thoughts as talking to her best friend and watching movies. Patient was able to identify her best friend and sister as individuals she feels comfortable calling when she is feeling and experiencing suicidal thoughts and urges. So here I'm identifying like patient's emergency contacts. And normally I would have this information like on a release of information. So that way I can call the emergency contacts if I'm not able to get a hold of the patient. Patient stated that although she lives with her mother, she does not consider her as a supportive resource and described her mother as, quote, not a safe person. Like emotionally safe. Therapist and patient created a safety plan should suicidal ideations intensify, which included coping strategies and emergency numbers. Patient identified the following coping strategies for her safety plan. So again, it's not enough to just say, I did a safety plan. Patient agreed, right? You have to put what was in the safety plan. So talking to best friend, increasing frequency of counseling, calling or texting crisis hotlines, drawing in sketchbook, watching movies, listening to music. Patient agreed to give her medication to her best friend as a safety measure in case intensity of thoughts increase. So here we removed the means, right? That's part of that action. We removed means. Patient agreed to utilize the safety plan and coping strategies identified in session and to utilize the emergency numbers that therapist provided. 911, suicide hotline, crisis text line, and Exodus recovery. Due to the level of suicidal feelings, patient agreed to increase frequency of counseling session to twice weekly. So again, here's another action plan. Patient agreed she will be able to keep herself safe and utilize the safety plan, no crisis in time of session. So do you see that I have two big chunky paragraphs about how there's no crisis right now and no further action needs to be made beyond we're increasing our frequency of contact, and we created a safety plan, we reviewed it, she agreed.